office worker?
Same. I'm calling it the sweatpants semester.
I'm dreading putting anything like real clothes back on. I don't know if they'll fit. Every time I go by the kitchen, I feel the need to see what else there is to eat. And I'm getting quite creative. Anyway, let's go ahead and get today started. After I lecture, what we can do is then open up conversation. I've started the recording here. If it goes well and we don't have a new textbook, hopefully I can use this maybe again next year, just as pre-recording. We do have a new Wilkins coming out. It's a pretty color, a different green than the ones that you've got. It's more of a hunter green, a smoky green. It's very pretty, but they've added some chapters and combined certain things. So it's going to be a mess with trying to get the fall together. That's just me whining. We are going to talk today with chapters 24 and 25. We'll go over chapter 24 first. Systemic and local drug delivery systems. The last chapter was on topical and rinses and those type of things. This is going to get into more of the systemic antibiotics, the local drug devices, as well as enzyme suppression therapies. Now, this is going to be a lot of review for you because you've had this also in DNH 142, and this overlaps your pharmacology. So the objectives are you're going to know about this stuff. So let's go over some terms. These are terms that you do need to know. Adjunctive means in addition to. So when we're talking about adjunctive therapy, that's always in addition to what you would normally be doing. So if you're root debridement, those type of things, the adjunctive therapy would be what are you adding on to that. Antibiotic resistance is when an antimicrobial agent is no longer effective in doing what it's meant to do. Chemotherapeutic agents, the drug is used to treat various forms of bacterial diseases as well as cancers. Controlled release delivery, now that's a biodegradable matrix that's slowly released from a matrix. So what we're talking about in dental hygiene is the Atrodox, which is your doxycycline, your Arestin, your Minocycline, and your Perio-Chip, your Chlorhexidine. Those are placed into the pocket and slowly released over time. Periodontal pathogens are bacteria that cause periodontal disease, and you know about the different complexes. Substantivity is the ability of a substance to absorb or bind to a surface, like the tooth surface and tissues and those type of things, to slowly be released over time. So substantivity in a mouth rinse is what we're looking for it to be bactericidal. And then systemic drug delivery is just what it means, the administration of the drug by mouth, either orally or parenterally, which is IV, IM, or subcutaneous. So things have changed from when I was a new graduate and we found out that bacteria was the root cause of everything. We were using antibiotics more freely than we are now. But what is the rationale right now for using antibiotics? Now, as an antiseptic substance, that can inhibit growth of microorganisms or kill microbes on contact. So we're using antibacterial soaps, for example. We're using antibacterial wipes. But an antibiotic is a substance that is synthesized by microorganisms that prevents or inhibits the growth of bacteria by stopping multiplication or killing the bacteria. So it's stopping the multiplication or killing the bacteria. And we're talking bacteria for antibiotics. Repopulation of the pathogens can occur within 60 days of perio-debridement. That's 2 months. After you've done all your root debridement, those pathogens can repopulate that pocket. So our job is to bring the patient back frequently enough to be able to disrupt those pathogens, as well as give the patient the tools to be able to disrupt those pathogens into the deep pocket, be it irrigation, whatever, and then also to see if they need any adjunctive therapy with other things. So other periodontal pathogens live in non-periodontal sites. So we know the mouth is full of bacteria. So our tongue, the tonsil, saliva, buccal mucosa, it's everywhere. And some of the bacteria is good and it's supposed to be there. But sites are a source for reinfection and must really be considered in the overall treatment process. So especially if you've got a localized periodontal pocket, you don't want that patient or you transferring those pathogens from one pocket to the next where they could set up residence and multiply, especially if it's in a deep pocket area where the patient can't disrupt that bacteria. So antimicrobial agents can really be instituted as a supplement, as an adjunctive need, okay, not a replacement during non-surgical and surgical therapies. So all of these studies that were done on what we're talking about is always in conjunction with scaling and root debridement. One does not replace the other. And antibiotics used indiscriminately can result in antibiotic resistance. I think I've told you back in the 80s, oh, you need quadrant scaling and root planing or root debridement. You are going to be on amoxicillin or tetracycline and metronidazole. Here are your two prescriptions. You are going to be on it. Well, we're not doing that anymore. But back then, it was standard operating procedure. We thought we were doing the best for the patient. So delivery systems can be local or systemic. Local is going to include the topical as well as the controlled release devices. All right, so topical delivers the agent or drug to an exposed surface, okay, such as the teeth or the gingiva. And the most common route for supragingival delivery is through a mouth rinse. But you know, just swishing with something isn't going to get underneath the gum tissue. So for subgingival, it's by oral irrigation or the use of controlled release devices. Now, oral irrigation can be great, whether it's with a cannula and the patient self-administers it, or with something like a water pick or a water jet device with a Perio tip that can be angled into the pocket. Controlled released delivery devices. Now, those are placed directly into the periodontal pocket, and the drug is released slowly over 24 hours or for the course of about 2 weeks. Okay, that includes fibers, gels, chips, powder, and ointments, and we're going to be getting into those. So those are the controlled release devices, and you're going to have experience with some of these in the clinical setting. There's also systemic systems, and that involves taking a tablet or a capsule orally with subsequent distribution of the agent through the circulation and into the subgingival pocket area. So by the time you take an antibiotic and it dissolves and it goes through your bloodstream, how much of that is actually going to make it into the pocket area? It's different if you've got, say, AA embedded into the connective tissue. But when you're trying to, say, halt collagenase production and other things, how much is reaching that gingival crevicular fluid? So we know that dental plaque is a biofilm, okay? It exists as a biofilm, and it's defined as a matrix enclosed bacterial population adherent to each other, so they're sticky, so they stick to each other and to surfaces. Subgingival biofilm can't be removed by toothbrushing or flossing or even antimicrobial agents. Those subgingival bacteria are pretty powerful things. So it's necessary to physically remove the biofilm by instrumentation, and then antimicrobial agents can be administered. So again, you have to remove the biofilm first, and then you can do your adjunctive treatment. The same is true even for lasers. Now, one of the research papers, we'll get into this later, was on laser therapy, and it was found through one of the studies that you could go through the laser with the laser first, kill off the bacteria, and then there's less bacteremia, bacteria going through the bloodstream during the scaling process. So we might be changing our philosophy on this as studies come out. But right now, you're removing the biofilm first, and then you're treating the pocket, even with the laser. The biofilm structure accounts for the rapid rebound or repopulation of the pathogenic bacteria. So our job as the clinician is to try and lessen the amount of bacteria that's left in the pocket so it can't grow quite as fast. Now, you've seen pictures like this of the structure of biofilms, and they've got these fluid channels, and then things break off and they float. This is just a very classic picture of the structure of biofilm, but it's a living entity. It's a living entity, and it changes, and the bacteria can communicate with each other. So let's talk about the systemic drug delivery. So we've got these antibiotics that are generally unnecessary for reducing plaque levels and treating gingivitis, with the exception of possibly the necrotizing diseases, because we've got spirochetes and other things that are invading the tissue. But systemic antibiotics are useful as adjuncts in periodontal treatment for patients with aggressive periodontitis and all types of refractory periodontitis. Now, that could even be a gingivitis person that is not responding to therapy. And again, our immunodeficiency diseases. So aggressive periodontitis, refractory, and immunocompromised or immunodeficiency diseases can benefit from systemic drug delivery. It's also used in the treatment of periodontal abscesses, where everything is very pussy. But antibiotics are classified either as bacteriostatic, which suppresses the multiplication of bacteria, or bactericidal, which kills the bacteria. So for bacteriostatic, we're inhibiting bacterial growth as well as the multiplication by inhibiting protein synthesis. Hopefully this sounds familiar to you. Broad spectrum antibiotics that affect both gram-positive and gram-negative microorganisms are used, and it's mostly used in locally aggressive periodontitis and aggressive periodontitis, as well as refractory periodontitis. So look at those types versus we were automatically putting everybody on these medications. So tetracyclines have something called a collagenase feature, and that affects the host response by inhibiting the production and secretion of collagenase by the PMNs. Now, collagenase, as you know, is the enzyme responsible for the destruction of collagen that makes up the connective tissue. So it's also been found, tetracyclines have also been found to inhibit bone resorption by affecting osteoclastic function. So it's got some good properties in it. What they have found, though, is tetracyclines have the ability to concentrate in the gingival crevicular fluid, right where we need it. And it exhibits higher substantivity than other broad-spectrum antibiotics, and it allows binding to the root surfaces with a slow release into the gingival crevicular fluid. So the nice thing about tetracyclines is it's found in the gingival crevicular fluid. It has substantivity over other antibiotics as well as binding capabilities. But it's got some drawbacks. Tetracycline upsets people's stomach. Now, a lot of things, just like with codeine, oh, I can't take it, I'm allergic to it. When you're asking medical history questions, are you allergic to anything? Yes, codeine. Oh, well, what symptoms did you get? Upset stomach. That is not an allergic reaction. It's an adverse reaction. But esophageal ulcers, nausea, vomiting, diarrhea. And as you know, with tetracyclines, stain on the newly formed teeth during enamel deposition. So ulcers, nausea, vomiting, diarrhea, you think the patient's going to be real compliant with wanting to take something like that? Usually not. So we've got these penicillins, the beta-lactams, which are bactericidal. The mechanism of action is inhibiting the bacterial cell wall synthesis. It has limited activity against gram-negative pathogens. So what are we after when it comes to periodontal disease? We want to get those gram-negative pathogens, but it's indicated primarily in acute periodontal infections. So if a patient comes in with a periodontal abscess, penicillin is going to be, or one of the cillins is going to be more effective than a tetracycline medication. And then we've got metronidazole, and that is specifically fights against the obligate or strict anaerobic microorganisms. Now, obligate, can go, it's kind of AC/DC. I can have oxygen or not have oxygen. I really don't care. It penetrates well into the gingival crevicular fluid, but not as high as the tetracyclines, and it's bactericidal, and it inhibits bacterial DNA synthesis. It's indicated for the treatment of NUG, and it's also indicated when barrier membranes are used during guided tissue regeneration surgery, and that's what we're going to be talking about next week. So if you've never heard of guided tissue regeneration, hold on. We'll be talking about it. And it's also used when in combination with amoxicillin or augmentin because it's a synergistic effect. So like I said, back in the 80s, we would put you on tetracycline as well as metronidazole. Erythromycin is bacterial static, and that inhibits bacterial protein synthesis. So I need you to know what the medication is and how it works, okay? Microlid antibiotic is not used in treatment of periodontal disease. It's only effective against gram-positive microorganisms, erythromycin. So it doesn't penetrate gram-negative bacterial cell walls or get into the gingival crevicular fluid. Now there's something called Alizide, and that's a second generation erythromycin with a little more broader spectrum, and it has fewer side effects because erythromycin can tear up a stomach. Patients hate taking erythromycin. Then you've got your Lincomycins, and they are bacterial static. It inhibits bacterial protein synthesis. Clindamycin is one of those that penetrates well into the gingival crevicular fluid, and it's active against periodontal pathogens, and it's useful in the treatment of refractory periodontitis. It's associated with development of pseudomembranous colitis, though, so that's not always our first drug of choice because of what some of the side effects can be. Then you've got your Quinolones. Again, bactericidal. It inhibits bacterial DNA replication. It's broad spectrum, and it's effective against facultative non-gram-negative anaerobes. Facultative non-gram-negative, anaerobes. And it's not actually an antibiotic because it's completely synthetic. One of the dangers is bacterial antibiotic resistance, and that's when an antibiotic will no longer be effective if administered later because the bacteria have become resistant to that antibiotic. These bacteria and pathogens are very smart, and they will alter their DNA so they can survive. It can lead to an increase in the incidence of the disease, and it also can lead to more diseases becoming more prevalent as the patient no longer has medicine that can fight certain diseases, and they'll become drug resistant. So these are patients that are more likely to become antibiotic resistant if they stop taking the medications prematurely. So we have to really counsel our patients that if it's for a 10-day routine, that they take it for all 10 days. You're going to start feeling better on day 4, but that doesn't matter. You need to be taking it for all 10 days. And also, what's very popular is self-medicating with leftover antibiotics, because they had 4 left in the medicine cabinet from the time they were supposed to be taking it before. So they'll just go ahead and self-medicate. So again, that partial dose really sets that person up for antibiotic resistance. So when we're doing a medical history and they're on an antibiotic for, their finger or for whatever it is, you want to find out what antibiotic they're taking, as well as how long are they supposed to be on it for, and how many days have they been on it. So I usually write down day 2 of 10, or day 6 of 10, or day 8 of 7, or whatever it is. That didn't make sense, 8 of 7. But that way you know where they are as far as with the medication that they're taking, and if they're taking it like they're supposed to. So those are the systemics. Hopefully you are familiar with those because of your pharmacology. So let's talk about the local delivery, the controlled release drug delivery, because that's what we are going to be working with as dental hygiene. Okay, we are going to be recommending these for our patients. But antimicrobial therapy that allows for therapeutic levels of a drug to be maintained in the periodontal pocket for a prolonged period of times, and that's that controlled release. Okay, substantivity. Treatment based on clinical findings, clinical response to therapy, and desired clinical outcomes, as well as the patient's dental and medical history, all need to be taken into factor. So we've got controlled release devices, and if the drug is released from the device beyond 24 hours, that's controlled release versus sustained release. And that's if the drug is released within 24 hours. So know the difference between those two terms. Controlled release is beyond 24 hours. Sustained release is within 24 hours. So one of the first things we had was something called a Perio chip, and it was chlorhexidine gluconate. It came in a little chip, and Perio chip is the name brand, and it's a gelatin matrix containing 2.5 milligrams of chlorhexidine gluconate, and it's indicated for use as an adjunct to instrumentation in the maintenance of patients with pockets greater than 5 millimeters or more, with bleeding on probing. So after periodontal debridement, the chip can be placed into that periodontal pocket, and chlorhexidine can be slowly released. So it comes in contact with the subgingival fluids, and it binds with the epithelium lining the pocket, and it has antibacterial action that occurs when the chlorhexidine is released over 7 to 10 days after the Perio chip resorbs. So it looks like a little popcorn hull, and they were a pain in the neck when we first started using them because they get very gooey and gummy, like a gummy bear. So we'd have to keep them in the freezer, and we'd have our forceps, or cotton forceps or pliers in the freezer as well. And we'd go and get it from the freezer, and we'd run back to the patient, because if once it got soft and room temperature, it just got too pliable and it wouldn't go subgingivally. They now make them where they don't have to be refrigerated, so they've changed the matrix a little bit, but chlorhexidine has gone under fire on not being the best thing to irrigate with, especially after scaling and root debridement. It interferes with the healing and the fibrin production. I have an article in Canvas. Please take a look at it. Many offices are still using chlorhexidine to irrigate with, and that is not what chairside, and that is not what the science is telling us. It's very different if the patient's doing it at home after some healing's taken place, but we don't do it chairside anymore. Now, doxycycline hyclate gel is called Atrodox. This used to be very popular. There's a little bit of a learning curve with this. You've got a powder and a liquid. It stays in the refrigerator. You go get it, and you pump, 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 pump. It takes 100 pumps. So you're talking to the patient while you're pumping, and then it all gets into one of these syringes, and then there's a little metal tip you put on that you can squirt it under. But it's a powder and a liquid that are mixed together and injected into the pocket. And once it comes in contact with the gingival clavicular fluid, it solidifies into a wax-like substance. Now, this is indicated as an adjunct to scaling and root planing procedures with patients with chronic periodontal disease. The studies are very good where it promotes attachment, reducing pocket depths, and reducing bleeding on probing. Now, again, there's a learning curve with this because once it gets in contact with any fluid, it sets up. So you have to get a wet gauze and know how much to fill the pocket area. Then you get your wet gauze with a finger and try and get that cannula out of the pocket. Otherwise, you're going to get this whole solid clump come out of the subgingival area as one big clump. And it's expensive. So this is really nice for patients who have multiple sites that you want to use, because once you mix the syringe, if you don't use it all, you need to throw it away. So if I had 12 sites on a patient, I would use Atrodox. The Perio offices I've worked in seemed to like the Atrodox better. It was, they were getting better results. This is 2 different offices than the Arestin. So again, it's personal preference as well as what do you find works best for you. What is the most popular thing now is the Minocycline hydrochloride, the 1 milligram Microspheres, and the name brand for that is Arestin, and that is a sustained release product. So minocycline is a tetracycline, but it's no longer acting and has a broad spectrum antibiotic activity. So Arestin is indicated as an adjunct to scaling and root planing for the reduction of pocket depths in patients with chronic periodontitis. So you will be doing Arestin applications. You have to do 2 in order to graduate. You are going to have plenty of patients to do this on. And we supply the Arestin with you. So I have, it's an Aura Pharma product, and I have set up a webinar for you all to sit in on to learn more about this, but it's something that you'll be seeing in private practice quite a bit. Minocycline hydrochloride, okay? So you'll be writing down in the chart that you've placed Arestin and then in parentheses, minocycline HCl 1 mg, and then, you know, on 14 mesiobuccal, 14 mesiolingual, you'll be telling in the chart exactly how many you placed. So we're talking antibiotics here. What are some of the precautions and contraindications? Well, subgingival placement for the devices containing these antibiotics or antimicrobials, you can't use if they have an abscess, okay? An acute perio abscess, you don't want to go shoving things in there. To me, it kind of makes sense. Oh, you've got pus, let's go, you know, let's stick something in there to kill all the bacteria. That's not the thing to do. Antibiotic products should be used with caution in patients with oral candidiasis because they've already got it, and the antibiotics is going to reduce their threshold for the microorganisms that are supposed to be in the mouth even further. And antibiotics also suppress the growth or kill bacteria that allow for the growth of other microorganisms, the good stuff, to allow other stuff like fungi to start taking hold. So it's not uncommon that we run into patients. These are usually immunocompromised patients or special needs patients that we see this type of thing going on. Enzyme suppression therapy. Okay, so we've talked about the systemic, we've talked about the controlled and sustained release. Now this is enzyme suppression therapy. And this is an inflammatory mediator that's produced by the host cells. Now remember those cytokines and prostaglandins, those react in response to bacteria and are partly responsible for periodontal tissue breakdown, bone breakdown, pain, Okay, they're the chemical mediators. And when produced in excess, these cells can induce destruction of healthy tissues. We have something called matrix metalloproteinases. Now again, the ASE is an enzyme. These are host cells, including the PMNs and fibroblasts, that respond to bacterial products by synthesizing and secreting matrix metalloproteinase, okay, we call them MMPs, in the host's connective tissue. So in oral healthy tissues, we've got fibroblasts synthesizing and secreting collagenase, which removes the old collagen and adds new collagen. So all collagenase is not bad. We have to have something to be able to take up the dead stuff. But in the disease state, the PMNs produce collagenase in excessive amounts, and that's when it starts destroying periodontal tissues. You've got too much of it. So there's something called Subantimicrobial-Dose Doxycycline, SSD. Okay, it's 20 milligrams, doxycycline 20 milligrams, sub-antimicrobial dose. So just by looking at that word, sub means below antimicrobial dose. So it's a sub-antimicrobial dose. Doxycycline has an anti-collagenase property, and at 20 milligram tablets of doxycycline, instead of what you need to use as an antibiotic, if I was taking doxycycline as an antibiotic, it would be 50 or 100 milligrams. But at 20 milligrams, it only works with the collagenase activity and doesn't have any antibacterial action. So you're not taking it for an infection on your finger. Okay, it's not going to work for that because it's not an antibiotic. It's sub-antimicrobial dose. But at 20 milligrams, it works in the gingival crevicular fluid with the collagenase. Doxycycline 20 milligrams is indicated as an adjunct to periodontal debridement to promote attachment level gain and to reduce pocket depths in patients with chronic periodontitis. It reduces the gingival crevicular fluid collagenase inducer levels, and it improves clinical outcome of periodontal debridement. Now, having said that, this was very popular in the 80s as well as the 90s, but what patients were having a hard time swallowing, so to speak, is that they had to take this because they had chronic perio, and we were recommending them to take it for the rest of their life to control their perio. Now, when they do that, it does a very good job of controlling the perio, but patient compliance is really not great with this. But even though the studies show that it works, so it's kind of gone by the wayside a little bit, and we're using it more sparingly, okay, because the patient really has to be motivated. So, antimicrobial treatment of inflammatory conditions with dental implants. We've got our Peri-implantitis and our peri-mucositis. So I'm going to talk about mucositis first, because that is the muco, think about mucosa, itis, inflammation of. So that's an ailing implant where only the gingiva around the implant is inflamed. So that is still a correctable situation because there's no associated bone loss. So what are you going to do as the hygienist? You're going to do good OHI, you're going to do non-surgical periodontal. You're going to maybe recommend adjunctive treatment, right? We consider this an ailing implant. It's not failed yet, but an ailing implant where only the gingiva around the implant is inflamed, we're hoping to be able to correct that situation with secondary prevention. If it continues, we then have peri-implantitis, okay? And that is the inflammatory process that affects the peri-implant bone, around the dental implant. So peri-implantitis is actual bone loss around the implant. And that is a failing implant, all right? If it's mobile, it's a goner. So when you've got a mobile implant with bone loss, really the best treatment is removal of that implant. and let the bone heal, maybe bone augmentation surgeries that we'll be talking about next week, and then putting in a new implant. Now, some periodontists will recommend the Arrestin to improve things and try and hold on to the implant for a little bit longer. So it really depends on the comfort level and expertise of your employer as far as what they're comfortable to doing. So as a hygienist, we will be treating and can treat chairside peri-implant mucositis. But if we have a failing implant and it's implantitis, peri-implantitis, that really requires specialist work. And if you're working for a periodontist, you'll be the specialist working with that. And you might be doing adjunctive therapy, including laser therapy on these particular patients. All right, let's take a look at some review questions. Which of the following procedures, I don't have the chat box up and I don't know how to get it up. Which of the following procedures most effectively remove supra and subgingival dental biofilms? So somebody's going to have to, oh, chat, here we go. I got the chat, okay. Everybody's saying C, periodebridement. And you are correct. Systemic antibiotics are indicated for chronic periodontitis. True or false? Okay, it's not indicated for chronic, not for systemic antibiotics. Dental practitioners should contribute to limiting antibiotics. Now that's a true or false. And let's look at the second statement. Overprescribing antibiotics can lead to antibiotic resistance. And that again is AA. Yes, true and true. Which of the following is an adverse effect that may occur when taking antibiotics? And we have bacterial resistance. Good job. In controlled release devices, if the drug is released from the device past, let's see, in controlled release devices, the drug is released from the device past 24 hours. In sustained release device, the drug is released within 24 hours. I apologize for my typo. Okay, page 335. True, true. Local delivery systems include local, systemic, and topical forms of administration. Okay, good job. Good job, yeah, because if it's systemic, it's not local, is it? Substantivity refers to the ability of the drug to bind to the root surface with a slow release. True or false? Tetracycline exhibits a high ability to concentrate in the gingival crevicular fluid. And page 338, we have true, true. All right, folks, we have just done one chapter. And I don't even know what time it is. Why don't we take a 5-minute break and come back and we'll do the last chapter. So before I go on, are there any questions? I have no idea when we went on break, so I'm just going to get started. And everybody can join me back at 1:15. What time is it? Oh, it's 1:15. This is perfect. Okay, let's go on to the next chapter, which is chapter 25, the principles of periodontal surgery. So we're going to talk in this chapter on gingivectomy, osseous resection, and periodontal plastic surgery. So a little bit of that guided tissue regeneration is going to be talked about. And next week, we will be talking about implants as well as periodontal regeneration. So can you grow bone back? Yes, you can. So that'll be next week. And then, believe it or not, we're done. So let's talk about some periodontal surgery. Okay, this isn't something that you will typically be seeing in private practice. I've had the pleasure of working with Perio as well as general offices that have done a lot of this, and that I'd be able to go in and assist occasionally, or I would do the IP, the initial prep, and then they would lay the flap and they'd have me go in and I could continue and finish the work. I couldn't because all the gums were there. So it depends on what offices you get to see what you'll be seeing, but a lot of times you'll be seeing them before surgery and then after surgery. But what are some of the objectives of periodontal surgery? Well, we want to reduce the pocket depths. We would love to regenerate periodontal tissues that were lost due to disease. We want to arrest the disease progression, and we want to maintain a maintainable oral environment for both the patient as well as the dental team. So we both have to be able to get access to these areas. And if we're having problems accessing them, can you imagine what the patient is going to have problems with? We also want to gain access to the root and bone for more effective removal of calculus and subgingival bacterial biofilm. Just think, if the gum tissues weren't there, we could all do a great job of scaling if we didn't have things in the way. So, indications for periodontal surgery: correction of mucogingival defects to improve aesthetics, the placement of dental implants, incision and drainage, IND, incision and drainage of abscesses or of either the gingiva or the periodontal tissues, and regeneration of the attachment apparatus that was destroyed by periodontal disease. Now, there are some contraindications. Oh gosh, I just lost everything. Wait a minute. There are some contraindications. The systemic diseases, if they have uncontrolled diseases, think about diabetes, hypertension, those type of things. Systemic diseases with excessive bleeding. You've got leukemia, hemophilia, renal dialysis patients. You need to consult with your doctor, with their doctor. You need to see if they're on medications that need to be altered prior to certain things. Anticoagulation medications, and there are so many of them out there. Some require INRs. Some don't require INRs. Some require monthly blood work. Others don't. So that's another important reason why we want you to have these drug cards ready. We can't keep everything in our head and know everything about every drug. So it's important that we refresh our memory. Warfarin and heparin are two of the big hitters. They require INRs, and you know, then you'll have to look up, well, they've got an INR of 3 or an INR of 5. What does that mean? These aren't things that you necessarily, after you take your boards, need to remember, because there are references for you. But if a patient's on a blood thinner, anticoagulation medication, it used to be about 2 weeks or 1 week before the appointment, the doctor would then start weaning them down and off of that medication. And then they'd put them back on it after whatever the procedure is. Well, what the philosophy is now is risk versus benefit. Is the patient more likely to have a stroke if they reduce or remove that medication versus if they don't? So just from the dental hygiene aspect of it, with the Coumadin, the warfarin, or the heparin, patients that I've had that have been on that medication, I have not noticed any extra bleeding than what I would expect to see given their level of oral hygiene. So if I had somebody that was on these medications and were stable and had good oral hygiene, their bleeding was under control. But if they came in and they were a biofilm perio mess, you can expect to have a lot of bleeding even if they weren't on that medication. So that's been my personal experience with it. Now, IV bisphosphonate, okay, if they're on IV bisphosphonate especially, but there's a lot of oral medications that don't have the same risk for that osteonecrosis of the jaw that the IV bisphosphonate has. But we do have a release form. It's not in the computer, a paper release form that the patient needs to sign saying that they've been made aware that there's this weird chance that something might happen. Now, with what we do in dental hygiene, it's going to be very, very rare. But if they were going in for an extraction or a crown lengthening procedure or an implant, that is where it would be more detrimental because they're actually doing things to the bone. Teeth with hopeless prognoses. All right, again, harm versus good. Are we trying to save a tooth to the point where there's going to be more bone loss in the end, where it's going to inhibit trying to replace that tooth? And then bad oral health. The patient needs to be able to take care of things. So the contraindications are really fairly straightforward. What's the preoperative preparation? Removal of soft and hard deposits. So we want them to be as clean as possible so that the tissue is as healthy as possible before surgery. Reinforcement of oral hygiene self-care. We need to be having a very motivated patient. Selective occlusal adjustments with or without antimicrobial or antibiotic agents. So they're doing an occlusal adjustment, all right? If there is a heavy hitter in there that's causing mobility, you want that mobility because of the occlusion discrepancy to be taken care of before any surgery. And complete initial therapy, IP is what we called it, because that may reduce or eliminate inflammation and the need for so much surgery. And again, you want to evaluate for surgery 4 to 6 weeks after the completion of your initial therapy. So we've got what we call a perio reeval in clinic that you're bringing the patient back for. The same thing happens in private practice. You're bringing the patient back and you are reassessing the tissues. Are things responding? Are they not responding? And if they're not, why? Is it because you have calculus being left behind? Is it some other factor, a systemic thing going on? Do they need to be retreated, re-instrumented, or just is it an oral hygiene thing? You're playing the detective at that reeval appointment. Some of the requirements for surgery: before surgery, you want the elimination of plaque retentive restorations. Now, that's not what you were doing, but you were doing the hard tissue charting. So oftentimes you're bringing them up to your employer's attention. Carious lesions should be repaired. Sometimes they will wait on these, especially if they are class 5 or class 5, excuse me, restorations until the new gum line area has been established. Hopeless teeth should be extracted, and medical clearance for poorly or uncontrolled systemic diseases, especially medical clearances. We want to guarantee as best we can a positive outcome for our patient. That makes the dentist look good, and that makes the patient like the dentist. So we try and cover our bases by every step possible. And some of that is getting a medical clearance for our questionable cases, because the patient needs to know it's a questionable case. Smoking as well. They're smoking. Some periodontists or oral surgeons won't even work on the patient while they're smoking. They make them stop a few weeks ahead of time because it reduces the amount of blood coming to the area, which will inhibit healing. So let's take a look at some of the periodontal surgeries. You've got the gingivectomy, which is a supragingival pocket reduction. So think about, it goes along with the periodontal plastic surgery sometimes, but think about a facelift for the gum tissue. You've got a pocket, 5mm pocket, but the tooth has no bone loss around it. Well, by shaving off either with a laser or a scalpel 2 to 3mm, you're going to have a 3mm sulcus, a longer tooth, and a healthier situation for the patient. So that's a gingivectomy. Then there's periodontal flap surgery, and that is used just to gain access to the root surface for the debridement process. So I was working in an office where it was a general practice where the patient would be coming back and the doctor would lay a flap, and then we'd coordinate our schedules where I would go in and be able to take care of the root debridement and the granulation tissue on the flap, and then he would come in and place the gum tissue back. And as I said, it's great. When you can see what you need to do, it's fabulous. So periodontal flap surgery is just to gain access. But then there's flap surgery with osseous reduction. So just take a look at the words. You're laying a flap of the gum tissue and you're reshaping that bone. Okay, so that's the treatment of the osseous defect. Then you've got periodontal plastic surgery. Now that is meant for correcting mucogingival defects as well as placing gingiva back. So those are your grafts. And then you have periodontal regeneration, which is an actual regeneration of lost periodontium. And that's what we'll be getting into next week. So you've got different types of healing responses. You've got repair, reattachment, new attachment, and regeneration. So let's look at repair here. Okay, repair is the healing of the periodontal tissues with tissues that do not replicate the original lost periodontium. So you're going in and you're just repairing, okay? It's not replicating. You have reattachment, and that's the reunion of epithelial or connective tissue to the root surface that was not damaged by periodontal disease. Reattachment is the reunion of epithelial or connective tissue. New attachment is the union of connective tissue or epithelium with the root surface that was deprived of its original attachment apparatus. So let's go back. Reattachment is a reunion of, okay, versus new attachment is a union of new stuff. And then you've got regeneration, and that is the reformation of the periodontal tissues that were destroyed by periodontal disease. So formation of new cementum, new PDL, new bone. All right, now this can't happen by itself. So that's why when we say periodontal disease, once it's lost, it's lost. Well, it is as far as the body's concerned, but there are some wonderful surgeries that can help regenerate. So the ideal treatment result is the goal for the most, if not all, surgical procedures. We want the ideal treatment result. Okay, what is going to be best for the patient? So sometimes in a treatment plan, you have to offer the patient a number of different options, from the Cadillac version, the BMW version, down to the Kia version, or whatever less expensive car is, okay? And then the patient can decide with what they're able to do and wanting to do. So for pocket reduction, okay, or pocket elimination, it's one of them is gingivectomy, and that's the excision or removal of soft tissue walls within the pocket. So the main objective is to reduce or eliminate suprabony periodontal pockets with horizontal patterns of bone loss and eliminate pseudo pockets, right? Horizontal bone loss. Contraindication, a lack of attached gingiva and the presence of infrabony or vertical bone loss defects. So gingivectomy is the removal of suprabony gingiva with horizontal bone loss. This is a prime example of a gingivectomy case. Healing usually starts within a couple days because the mouth is so vascular, but this is delayed passive eruption. You can see on the before picture where the gingiva is not gone above that height of contour. So you laser or trim or electrosurge the gingiva to make them more aesthetic, okay? So the gingival margins closer to the CEJ gives them a longer tooth, okay, and a more aesthetic smile. Then you've got your periodontal flap surgery, which is designed to gain access to the underlying bone and root surfaces. So the flap is a loosened portion of gingiva, so you can see the alveolar, and you take the alveolar mucosa off, and so you can actually see the root surface and the bone, and you can effectively debride those areas. So we've got different kinds of flaps, and yeah, you got to know what the words are, okay? So flaps are classified based on the tissue components and the final positioning of the flap. So the tissue components, you've got full thickness or mucoperiosteal flaps, or partial or split thickness flaps. So a full thickness or mucoperiosteal flap includes the gingiva, alveolar mucosa, periosteum that's reflected from the root, and the underlying bone surfaces. So a full thickness or mucoperiosteal flap really flays everything open, versus a partial or split thickness, the periodontium and some connective tissue is left attached to the bone and are not included in the flap. So you're just trying to get to the root surface with a partial or split thickness flap. Then the final positioning of the flap can be apical, coronal, or laterally. Okay, so think about where you want that tissue to be. Do you need to tighten up a pocket area like a facelift? All right, so that would be more apically placed. Okay, that flap would be more apically placed, closer to the bone. Laterally is just the way it sounds. All right, or stretching the tissue coronally. All right, the modified Widman flap is another one, and that is most frequently used as a periodontal procedure. It's direct visualization with debridement of deep pockets. It allows for complete removal of the pocket epithelium, and the healing that takes place is by primary intention. Now remember what the primary, secondary, and tertiary intentions are. Contraindications for a Widman flap, modified Widman flap, are bony defects that need to be recontoured or regenerated. So a modified Widman flap is just soft tissue. Just soft tissue. All right, it's typically done on the distal to the third molar after a third molar extraction, let's say, and the patient's got a deep pocket on the distal of their second molar. Okay, and that pocket needs to be resolved. So they remove some tissue and bring it together and do it that way. So that's a modified Widman flap. I've only seen it on the terminal molars. We like getting third molars out. If a patient needs a third molar out, we like them to do it while they're young and healthy and the bone can fill in. But if they're 35 and then they have an impacted third molar out, that bone doesn't like to grow back. So oftentimes the patient needs to be counseled that there might be a bony defect there. And because of that, we might have to do another procedure. And that's what that procedure would be. Okay, let's talk about the healing intentions. You need to know primary, secondary, and tertiary intentions. Primary intention occurs where the wound heals by fibrous adhesion. Secondary intention occurs where the wound, and I apologize for my typo, is left open. And tertiary intention occurs when the wounds are complicated by infection and it's healed by contraction of scar tissue and things. So primary intention is, and secondary intention are usually what we see in dentistry. Now we have apically positioned flaps as well. Full or split thickness flaps are made with the internal bevel incision that is sutured or positioned apically at or near the level of the alveolar crest. You don't need to know this, but you do need to know that when a flap is made and incisions are made, it is a very purposeful incision with the shape and the depth and the angles that the dentist or periodontist is doing. For apically positioned flaps, you want to eliminate moderate or deep pockets by positioning the gingival tissue apically. You want to lengthen the clinical crown. That's a crown lengthening procedure. And you want to also increase that zone of attachment. So if you're replacing that tissue coronally, you're trying to stretch it and get it at a higher level. Contraindications would be aesthetic concerns. We don't want that deadly black triangle disease, especially in the anterior area. Patients with a high risk for root caries, because you're apically positioning that flap, there's going to be new cementum exposed. So you need to take that into consideration, as well as advanced bone loss. How much structure is going to be left? So apically positioned flap with bone recontouring, it's very barbaric. And it's very bloody. I don't know if anybody's had the opportunity to assist with this or not. All of this is kind of barbaric in retrospect. Okay, so let's talk about osseous recontouring. So we're looking at the bone. You need to know what otomy is versus plasty. Osteectomy, excuse me. Ectomy is the removal of anything. Okay, so osteectomy is the removal of supporting bone. Osteoplasty is the reshaping. So oftentimes things need to be reshaped as well. Because think about how bone loss happens. It's not a nice, smooth procedure. It's very chunky and cavernous. So we want to create an optimal biological and physiologic contour, all right? To reduce that bony irregular contour, we want to eliminate infrabony pockets and eliminate bony wall defects. Remember those 1, 2, 3, 4, 3 wall defects? So the indications would be to permit optimal flap by reducing exostosis, to eliminate shallow infrabony pockets, to open furcation areas for maintenance. So you're either making it a class 3 into a class 4 furcation, so the patient can get a proxibrush or something through that furcation, and to lengthen the crowns for restorations. If there isn't enough tooth structure to support a restoration, you need to supply that tooth structure by doing a crown lengthening procedure and lowering the level of the bone. So for osseous recontouring, you've got the contraindications, the patient with periodontitis. Now, if they've already lost a lot of bone, you can't be taking a lot of bone away already. Then you've got where aesthetics are unacceptable in appearance. So think about, again, the maxillary anterior teeth. If they already have open embrasure spaces and they've got 6 millimeter pockets, and you do osseous recontouring and that bone is up to a higher level, you're going to make the aesthetics in those spaces even worse. And you also don't want to do it if there's not enough supporting bone around the adjacent teeth. So technique, very straightforward, local anesthesia. Flap is reflected from the root to the bone. Okay, and if the bone has ledges, then you need to, then those ledges need to be reshaped. Okay, and it's usually a high-speed handpiece, lots of water. You're in there irrigating as an assistant, and that's an osteoplasty. Then if there's an infrabony defect, an ostectomy occurs, and that again is with the burr as well as hand instrumentation to reshape that bone, and an apically positioned flap is then placed. And this came out of your book on the different steps. Ostectomy, okay, and osteoplasty. So for the healing with this, you have that long junctional epithelium, okay? And because everything's been reshaped and recontoured, the patient will oftentimes have recession leading to root exposure. So you need to be sending the patient home with the knowledge that they're going to be longer in the tooth, so to speak, and they have newly exposed tooth surface that needs to have as much fluoride as possible, and that the teeth might be sensitive for a while. So here are, some toothpaste with potassium nitrate in it, or whatever you want to do. Okay, the healing time required is 2 to 3 months. The patient will have post-op instructions, both verbal and written. So if they're seeing a periodontist and they come to you, they will be the ones telling you, Dr. Smith said, don't touch this area here for 6 months, okay? They're well informed with that, but we also have to go through the chart before we bring our patients back to know what they've had done. Now, this is typical crown lengthening procedure. It's called crown extension also. It's designed to expose more of the tooth structure. So this is delayed passive eruption where the teeth just haven't, the gum tissues haven't responded to where they're supposed to be. So this patient also, as you can see, had veneers placed. Look at number 7. But what they're doing now for some patients, instead of trimming these gum tissue areas, they're putting Botox on the upper lip. And that Botox will allow that lip not to retract when it's being used and smiled, and it'll keep that lip line a little bit lower. So depending on what the situation is. So, and you have to keep that biological width in consideration. So this is a crown lengthening procedure. This is what happened to me. I broke a tooth and I broke it off underneath the gum line area. So there wasn't anything to put a restoration on. So I had to go through the root canal therapy, and then the doctor had to shave some bone around my broken tooth so he could then fabricate a crown around it, and there was a stub for the restoration to hold on to, and that's a crown lengthening procedure. Not a lot of fun. Some call it crown lengthening. Mrs. Martin had an employer that called it root shortening, because that's what you're really doing. You're shortening the root. But with anything, you want to keep that biological width in consideration. Now remember that biological width is that soft tissue that's occupied by the junctional epithelium and the gingival connective tissue. You need that space. You need that space between the attachment and the bone. Otherwise, you will have invaded that biological width. So the margin of any restoration should not be placed within that space, and that is at least 2 millimeters. So that's what the dentist needs to configure when they're recommending certain things for their patients. Where is the, what is the biological width? Okay. If they invade that space, what happens is there will be chronic inflammation, and that gum tissue will eventually recede, because the body will create the biological space. Now there's also something called root resection, and that is not done very often anymore, but before implants, we were doing them a lot. And that is when you have a class 3 or 4 furcation, and there's part of the root that's been resorbed. It's very technique sensitive. The healing time is great, and it is also one of those heroic things that we used to do to try and save a tooth. So if just one root of a multi-rooted tooth was bad, the tooth would undergo root canal therapy, and that root would actually be amputated. So then it would be holding on with 1 or 2 roots if it was a 3-rooted tooth. Okay? It really freaks you out when you're probing. Freaks you out when you're probing if you don't remember that that has been done. So there's root resection, which is the removal of a root while leaving the crown of a multi-rooted tooth in place. Then there's hemisection, and that is literally splicing the tooth in half, a hemisection. And this is a root resection, something that you'll see radiographically. And look at that bony defect. So a proxibrush would need to go through that. It's also called bicuspidation or bisection of the root, okay, because you're splitting the root. But naturally, the tooth needs to have root canal therapy, okay? Long-term survival is not predicted. This was one of those heroic things that we did. Today, the dentist would be recommending extraction and an implant. Periodontal plastic surgery, think about your mucogingival defects. Surgery corrects the defects in morphology, position, and the amount of gingiva. So what are some of the indications? An inadequate attached gingiva, so you've got your mucogingival defect, elimination of frenum pulls, persistent inflammation or bleeding, progressive gingival recession, which is why our gingival margin and CAL is so critical when we're doing our periodontal assessment. Sometimes they need to deepen the buccal vestibule, especially if dentures are going to be involved, and for aesthetic reasons as well, to fill in the black triangle, for example, and modification of edentulous ridges prior to prosthetic reconstruction. So if the patient's been edentulous for a while, especially on the mandibular arch, that bone just disappears. And there's nothing to put an implant in. So reconstruction needs to be done. So a frenectomy, you can see where the frenum is right here, and the probe is going down. It's only 3 millimeters, but you can see that it is it's invading. There's a mucogingival defect there. So this has been not lasered, but that is where a scalpel has done that. But a laser looks similar to that. And after healing, there you go. No more frenum pull. So like everything else, we've got classifications, right? And there's classification for recession. So it's the apical position of the free gingival margin onto the root surface. And these are Miller classifications. And Miller has, we've got Miller and Glickman, if that sounds familiar, for the classifications that we use. Okay, so this is Miller for recession. So just take a look between 1, okay, and where that mucogingival line is. 2 goes beyond, okay, but there's single teeth. 3, multiple teeth that goes beyond, and a 4, multiple teeth with other defects going on. So 1 is the simple to 4, okay, and that's what I want you to take away from that. I'm not going to be asking you what are the parameters of a class 3 recession. If you're working in a perio office, you will be using those though, and as part of your description, just as we say type 1 embrasure or type 2 embrasure spaces. Okay. Types of soft tissue are used to treat mucogingival defects. You've got the donor site, and that's the area of the mouth where the gingiva is taken, and then the recipient site. That's where the gingiva is needed. And there are different types of tissue grafts. You've got your free gingival graft, your pedicle graft, and your connective tissue graft. So your pedicle graft is also called your laterally positioned flap. And that's when you move the gingiva from an adjacent tooth or an edentulous area that has good gingiva to another tooth beside it that has inadequate tissue, and that's the recipient site. So you're moving it from the donor site to the recipient site just by smooshing it over. It's freed on 3 aspects. Okay, so you've got 3 walls or a box, and it's attached, still attached with the blood supply, so things can be moved over. There's no underlying bone or fenestration being present here, and that's really nice for a single site recession area. So a V shape or a square shape is made around the recipient site. The area is planed and a full flap is elevated. Then it's sutured and for pressure application for 4 to 5 minutes. Periodontal dressing is sometimes placed, and you'll be getting into what a periodontal dressing is, and we'll be making them whenever we can have a dental materials lab. And follow up 1 to 2 weeks for the suture removal and dressing removal. Dressing removal first and then suture removal. And that's something you might be involved in as a hygienist. All right, so you can see that there are sutures here. So all they did was take the gum from one area of the mouth and move it over, okay, and suture it in the middle there. And it's got nice healing. Complete maturation is in 1 year. Pedicle graft. Great for recession. It doesn't cover all the recession. So you can see where the, this is where the surgical site is, and complete healing here. Looks good. So that's on the lingual, and then another one's on the facial. So even after 2 weeks, it's looking pretty good. Double flap papilla is a modification of the laterally positioned flap. You don't need to know about that. Free gingiva soft tissue graft, that's where the donor site is located away from the recipient site. So it's usually the maxillary palatal tissue. They'll take a little rectangle piece of keratinized tissue, and it's used for augmentation of the attached gingiva, more so than root coverage. And they suture the donor tissue from the palate to the recipient bed, right? And post-operative instructions are given, and the patients, again, no smoking, be careful. Healing is in about a month. You don't get root coverage with a free gingival graft. Now, I was a new dental assistant, and I was doing my first graft with my little silver surgical volume evacuator, and I was trying to get this blood here, and what I ended up doing was taking the donor site and the tissue, and it went right up that tube. Employer was not happy. But take a look at this. See how white and thick and keratinized this is? It's placed over here where the mucogingival defect is. And this tissue is going to remain looking like this. The color of the tissue is the color of the tissue that it was taken from. So the palatal tissue is usually lighter in color than where you're putting it. And this is post-operatively here. It's still got some healing to do. However, on that lower right picture, you can see that there's not a lot of root coverage there. And this is what it looks post-operatively here. This is not the same mouth, but we used to call it a wad of bubble gum. But they've got good attachment. The lower lip usually covers that, so it's not an aesthetic situation there. Then in the 80s, there was this thing called SCG, subepithelial connective tissue graft. It's been around for a long time now, but it's used for root coverage for single or multiple teeth. And this is the standard practice right now, along with other things. But they found that there's less shrinkage of the tissue after the new tissue's been found. The nice thing is there's no opened wound on the palate. When I go back, this would be open. And you talk about pain to the point where sometimes you would make a little flipper, like a little retainer, and the patient would then wear that just as a covering there, because that hurts like a son of a gun. Right, so there's no open wound on the palate with your connective tissue graft. You've got better blood supply, better aesthetics, and the healing time is in about a month. So the nice thing is that you get great root coverage, and I apologize for my fuzzy pictures there. But look how far down this recession is here with the mucogingival defect, and look how much root coverage there is, and that's just going to get better and better. So they go in, and instead of taking that rectangular piece of outer tissue, they go into the palatal tissue, and they take some of the subepithelial connective tissue that's harvested from the palate, right? So they're going underneath that to take the tissue, the donor tissue, and then incisions are made, and for the donor site, and all that vascularity and everything is just going to be very nice and cohesive, and then the graft is sutured at the recipient site. So believe it or not, this is not as painful as it looks, from what I've been told. Okay, so this again are some surgicals. Subepithelial connective tissue graft is great for root coverage. Something else that's used for root coverage is guided tissue regeneration. And that uses a barrier membrane that prevents the gingival tissue from contacting the root surface. Okay, so it's creating a space to allow for regeneration. So a full thickness flap is raised, so they reflect everything. And then a barrier membrane is placed over it. It used to only be Gore-Tex. And that then is placed and sutured in. Now they're using resorbable membranes. So they absorb or resorb, so you don't need a second surgery to go in and take that membrane out. Originally you went in and then 2 weeks later you'd go in and they'd resurgically open to a little bit to take that membrane out. Now everything just kind of dissolves. But the home care is not brushing the area for 6 weeks. They usually have touthettes and things, those little sponges that they are swabbing with. Very good results with this. So there are things that can actually regenerate, and one of them is called alloderm, and that is a regeneration tissue matrix. It's a biomaterial from human tissue, alloderm, human tissue. So all epidermal and dermal cells are removed. It's an attempt for root coverage. It needs to be refrigerated and then rehydrated. Alloderm is very popular in the surgery world for furcation areas. Okay, so you can, this is the furcation area here in B. In A, you don't really know what they're going after, all right, but look at the D after as healing and root coverage, all right, and that will only probe about 2 millimeters. Now, one of my employers did a lot of speaking and teaching, and he would have the patient back. This would drive him nuts, the aesthetics, and he wouldn't want the patient to go through some sort of plasty to make that look better. That would be unacceptable for him. Sutures are used to adapt the flap of the tissue. There are absorbable and non-absorbable sutures. We've gone over this in 142 a little bit. 3 or 4, 30, 40 are usually used. So just keep those numbers in your head. The higher the number, the smaller the suture. Just like with the lumen of the needles, if you have a 30 gauge needle, that's a very thin, flexible lumen versus a 25 gauge needle. So the higher the number, the smaller the suture goes along that. And you know how I love tables. When I sit through the board reviews, they go through all of this with you again, because there are some board questions that creep up with sutures. I'm not going to be asking real particular problems, but know that silk, for example, is non-synthetic, it's natural, versus nylon and polyester is synthetic. The new one is the PTFE, all right, and that's a synthetic. It's got Gore-Tex, it's got a lot of nice strength to it. So know the difference between plain gut, chromic gut. Gut makes it sound like it's a natural product, all right? So no natural versus synthetic. They've got absorbable versus non-absorbable sutures. Absorbable membranes, the natural or plain or chromic gut, comes from the intestines of sheep or cows. It's not very strong. It knots easily, but it absorbs through proteolysis. I'm not seeing a lot of that used anymore. So synthetic is more popular and it's easier to handle. And once it's knotted, they won't loosen up. It does cause less tissue irritation because it's a synthetic, right? And less inflammation. Resorption is through hydrolysis, usually 10 to 15 days. So think about it. You don't have to remove sutures 10 to 15 days. They've either fallen out or absorbed. Non-absorbable sutures, silk is most frequently used. That can elicit some tissue inflammation, slightly like an allergic inflammation. And they need to be removed no later than 10 days after surgery. Suture techniques. Just know the words. Interrupted suture is most commonly used. That's tied with a surgeon's knot. Other sutures include continuous. Now think about interrupted versus continuous. You think interrupted is one tooth tied off, then another tooth tied off. Continuous is where everything is combined, tooth to tooth. Mattress, sling, periosteal tack. These are interrupted sutures. So you've got a tie, a tie, a tie, a tie, versus a continuous that would be going all the way through. Now, periodontal dressings, look at that as a Band-Aid inside the mouth or a dressing inside the mouth. Some offices use them, some don't, but it helps keep the tissue in close contact to the bone and the tooth. It also protects the surgical site so the patient's more comfortable. But on the other hand, think about warm, dark, moist. It's a breeding ground, okay? And it needs to be placed judiciously because you don't want it too high up on your mucobuccal fold there or too low here. So you're going to have an experience in dental materials in placing on a mannequin a periodontal suture. I haven't done this since I was a dental assistant. I've never done this as a dental hygienist. But hygienists are oftentimes giving the post-operative instructions. Anything we do, we want to say it and give it to them in writing, right? Even in oral hygiene instructions. If there's a pamphlet we can give the patient, give them the pamphlet, but written and verbal. And of course, we also want to document that we gave them verbal and written, okay, in post-op instructions. So when you're doing your templates in clinic, it's going to be asking you, especially after periodontal debridement, not treatment plan, after the dentist comes and does the hard tissue, and we refer them back to their home office, the dental referral, we are writing down that we gave them something in writing. One of the complications that can happen is syncope. I'm not going to really go into that, but it's because you've had this in medical emergencies, but it's happened. I've had one patient faint on me in 40 years, but we have had instances in the clinic. We've had fainting in the clinic. We've had, let's see, a seizure in the clinic. We've had diabetes, insulin or sugar reaction in the clinic. So you just never know. And I've been working in the clinic more than private practice in the last 8 or so years. So I don't know what you all have come in contact with in private practice, but we want to stop the treatment, make sure the patient's okay, and take the vital signs. And I can tell you the EMT are going to want to know what the blood pressure and vitals were before you started the procedure. I can guarantee that. And if you don't know, it's on you. You know, what was it before they started? If they were 160 over 110 when they walked in, and you didn't know that, then anyway, end of lecture. So, suture complications, local anesthetic can be a complication in and of itself. The patient can be having a very fast heart rate, especially with the epinephrine. They're anxious to begin with. That fast heart rate then makes them even more anxious, and they could even have an anxiety attack. So we need to use our psychosedation to try and keep them calm, right? Epinephrine also helps with bleeding, but if they're coming in with bleeding, we need to know where the origin of the blood is coming from. Also, we have to have the patient know to apply direct pressure with the gauze, tell them about the tea bags if they're still bleeding. Ice packs, the sooner they can get an ice pack on before they even leave the office, they should have that ice pack on the surgical area, 20 minutes on, 20 minutes off to reduce swelling. The more manipulation of tissue and bone, the more pain the patient is going to be experiencing. So what studies have shown is that if you can pre-medicate your patient with an analgesic before the appointment, it manages their pain even better. So you can have them with the doctor's okay, of course, depending on what's being done, have them take 4 ibuprofen, for example, before they come in for the dental procedure. They have the dental procedure. They are given Marcaine, or a long 8 to 12 hour long-acting anesthetic. They go home, they take more ibuprofen. Everything's kicked in by the time the anesthetic has worn off. It doesn't do the patient good to then be in pain and then take the anesthetic, or the analgesic, excuse me. You want them to precipitate before the pain. And I see another typo here, I apologize, but the role of the dental hygienist, okay, we have to have the patient maintain good oral hygiene. We will be seeing them oftentimes at the 7 to 10 day post-op visit. If they're not booked on our schedule, we want to go in and say hello, what's the tissue look like, and give them our pearls of wisdom with what we can do. The Perio office, one of the offices I was in, I did a lot of the post-op and visits and suture removal. You always want to count the number of sutures. If you are removing them, take a look at how many were placed and count how many you got. Okay, you don't want to be leaving any of them in there. And being hygienists, we want to try and debride very gently, supragingivally, as much as possible. So a patient's gone under surgical procedure. What are some of the things that they are going to experience? Increased tooth mobility, okay, increased. Now that can be an extension of inflammation into the periodontal ligaments just by the trauma of the surgery. Could be because bone was removed around the tooth, but usually within about 6 months, the mobility will return to the pre-operative condition. So you have to let the patient know that this is a common side effect and will resolve itself, but you do want to check for fremitus as well as occlusal prematurities, because nothing's going to respond to that. Gingival recession is going to occur after gum surgery, especially if it's for pocket elimination. So we want the patient to maintain meticulous oral hygiene. We need them to know that these teeth may be sensitive. It's going to be temporary. And here we've got some good stuff to help you. Potassium nitrate is a good desensitizing agent. Stannous fluoride is another excellent one to prevent sensitivity as well as prevent demineralization. Okay, let's go on to some questions here. The term surgery is not a generic word to describe a branch of, hold on, I got to move my mouse here, a branch of medical science concerned with the treatment of disease or injuries by manual or operative means. The term surgery is not a generic word. Now I got to get my chat box back up. Okay, page 349, jot down, all right? The term surgery is a generic word to describe the branch of medical science concerned with the treatment of disease and injuries. Periodontal surgery does compensate, let me see here. Oops, sorry. Periodontal surgery does compensate for the patient's poor plaque control. It will not routinely produce miraculous or complete regeneration of all lost periodontal tissues. Okay, periodontal surgery does not compensate for poor oral hygiene, never, and it will not routinely. You see the word miraculous in there. Okay, root resection is indicated for a patient with furcation type 2 with bone loss. Or is that without bone loss? I can't see. It is usually done on multi-rooted teeth with defective, decayed, or resorbed roots. All right, gingivectomy is the excision or removal of soft tissue walls. All right, remember that 1 wall, 2 wall, 3 wall defect. Okay, so think back about what that is as well. The FDA regulates manufacture of medical devices such as sutures. The knot of a suture should be on the lingual side for aesthetic purposes. All right, the knot of the suture should be on the buccal because it's easier for us to see and remove. Tooth mobility increases after surgery. True or false? Patients should be advised that this condition may return to preoperative levels in 3 months.
Sorry, Misty, we don't see the PowerPoint.
Oh. Okay, what am I doing wrong? Well, okay, tooth mobility increases. I can't find what I'm doing. I'll read it to you again. I don't know where my slides and everything went. Tooth mobility increases after surgery. Is that yes or no? The patient should be advised that this condition will return to preoperative levels in 3 months. So this is on page 374. The first statement is true. And the second statement is false because it takes up to 6 months for the preoperative level to return. Another question, regeneration is the blank of the periodontal blank that were destroyed by periodontal disease. So we've got reformation in ligaments, destruction of tissue, reformation tissue, or destruction in ligaments. So regeneration is the reformation of the periodontal tissue that were destroyed by the periodontal disease. Okay, so page 350. Regeneration is the reformation of the periodontal tissue that were destroyed by periodontal disease. Okay, and now I've got a little funny cartoon up that nobody can see. So, that is it. Now I don't even know where. Okay, so anyway, before I log off, since I can't see anything, are there any questions?
No, thank you.
Okay, thanks everybody. Thanks for coming. I apologize for the snafu at the end.
No worries.
Okay, that's it.